Welcome back to Nephrology Notebook. Today we are taking a deeper look at intravenous fluids, not as background orders, but as real pharmacologic therapy. We will move from physiology to clinical trials to practical bedside stewardship. Before we start, this video is for educational purposes only and is not individualized medical advice. Any patient case discussed is hypothetical and used only to illustrate clinical teaching points. The audience for this talk is interns, residents, fellows, and attendings who order fluids every day. The goal is not to memorize one preferred bag. The goal is to ask better questions. What problem am I treating? What compartment am I trying to support? What toxicity am I risking? And when should I stop? The central teaching point is simple. Intravenous fluids can restore perfusion, but they can also cause edema, acidosis, congestion, dysnatremia, and kidney stress. Once we treat fluids like drugs, the rest of the lecture becomes more practical. The first mindset shift is that a fluid order should look like any other prescription. We should be able to name the indication, the type of fluid, the dose, the rate, the reassessment trigger, the stop point, and the toxicity monitoring plan. Normal saline is familiar, but familiar does not mean physiologic. 0.9% sodium chloride delivers a high chloride load. In small amounts, that may not matter. In large volumes, especially in critically ill patients or patients with limited kidney reserve, chloride can contribute to hyperchloremia and non-anion gap metabolic acidosis. The bedside mistake is writing fluids without defining the target. Are we treating shock, ongoing losses, maintenance needs, medication carrier volume, or sodium correction? Those are different prescriptions. With that prescribing framework in place, we need to review which compartment we are actually affecting. A typical 70-kilogram adult has about 42 liters of total body water. Most of that is inside cells. Only about 14 liters is extracellular, and only a small fraction of that, roughly 3.5 liters, is intravascular plasma. That matters, because when we give an isotonic crystalloid, it does not stay entirely in the bloodstream. It distributes through the extracellular space. After equilibration, much of the administered volume is interstitial, rather than intravascular. So the immediate target in resuscitation is not total body water. It is effective arterial blood volume and tissue perfusion. That is why the same liter can help one patient and harm another. The next step is defining effective arterial blood volume more carefully. Effective arterial blood volume is the effective fullness of the arterial circulation. It is not a literal compartment that we can draw in a beaker. It is a functional state determined by intravascular volume, cardiac output, arterial tone, venous return, and neurohormonal response. The body senses arterial stretch through baroreceptors. When arterial filling is low, the sympathetic nervous system, the renin-angiotensin-aldosterone system, and vasopressin activate. A terminology point is important here. AVP, or arginine vasopressin, is the same hormone many of us learned as ADH, antidiuretic hormone. The names differ, but the water-retaining signal is the same. Clinically, we monitor the response using blood pressure, pulse pressure, mentation, capillary refill, lactate, urine output, and trajectory. Once that concept is clear, the cirrhosis and heart failure paradox becomes much easier. Here is the case frame. A hypothetical patient with decompensated cirrhosis has tense ascites, leg edema, a low urine sodium, and worsening kidney function. Question: are they volume overloaded or volume depleted? The answer is that both statements can be clinically true, depending on the compartment. Total extracellular sodium and water may be high, shown by ascites or pulmonary edema, but effective arterial blood volume may still be low because of arterial vasodilation, low forward flow, or altered venous capacitance. That is the paradox. The patient can be edematous and still have arterial underfilling. So the decision is not dry or wet in a simplistic sense. The decision is whether perfusion, congestion, or both are driving the current problem. That leads directly to the next common pitfall: overinterpreting urine sodium. Let us continue the case. The urine sodium is low. Question: does that prove low effective arterial blood volume? Answer: it supports avid sodium retention, but it does not prove the diagnosis by itself. Low urine sodium can fit arterial underfilling in cirrhosis, heart failure, true hypovolemia, or hepatorenal physiology. But the interpretation changes with diuretics, chronic kidney disease, acute kidney injury, tubular injury, RAS blockade, bicarbonaturia, adrenal disease, diet, and timing. Diuretics can raise urine sodium despite low effective arterial blood volume. Tubular injury can make sodium reabsorption ineffective. Severe renal hypoperfusion can also create misleading patterns. So for the teaching case, the urine sodium is one clue. The answer requires bedside perfusion assessment, congestion assessment, medication review, urine sediment when relevant, and repeated reassessment. With that clinical lens, we can now ask what the fluid itself is doing chemically. The chemistry of the bag matters. Human plasma sodium is usually around 136 to 145 millimoles per liter, and chloride is about 98 to 106 millimoles per liter. 0.9% sodium chloride contains 154 millimoles per liter of sodium and 154 millimoles per liter of chloride. That chloride concentration is far above plasma. Lactated ringers and plasma light are closer to plasma chloride and contain metabolizable anions that act as buffers after metabolism. The point is not that saline is always wrong. Saline has important roles. The point is that large saline exposure is not chemically neutral. To understand why chloride changes acid-base status, we need to introduce strong ion difference. Strong ion difference is a way to understand acid-base effects from charged particles. In simplified terms, plasma has more strong cations than strong anions, leaving a positive strong ion gap. Bicarbonate participates in maintaining electroneutrality. Saline has equal sodium and chloride, so its apparent strong ion difference is 0. When enough saline is infused, chloride rises relative to sodium. The plasma strong ion difference narrows, and bicarbonate concentration falls. Balanced crystalloids are different because lactate, acetate, and gluconate are metabolized. After metabolism, they function as bicarbonate-generating anions and increase the effective strong ion difference. That distinction explains why balanced fluids tend to be less acidifying than saline. The first clinical mechanism is hyperchloremic metabolic acidosis. Large volume saline can produce a non-anion gap metabolic acidosis. This is often called dilutional acidosis, but dilution alone is an incomplete explanation. The more precise mechanism is chloride displacement and reduction in strong ion difference. As chloride rises, electroneutrality is maintained in part by a fall in bicarbonate concentration. The carbon dioxide generated from bicarbonate buffering is exhaled, but the measurable result is a lower bicarbonate and a more acidemic serum profile. At the bedside, this can matter when a patient is already acidemic, has limited respiratory compensation, or is receiving repeated saline boluses. It should not lead to panic after 1 liter. It should lead to intentional fluid selection and monitoring. The second mechanism is the kidney response to chloride delivery. The macula densa senses sodium chloride delivery through the sodium-potassium 2 chloride transporter. When distal sodium chloride delivery is high, the kidney may interpret that signal as upstream hyperfiltration. In experimental settings, high chloride delivery activates tubuloglomerular feedback. The macula densa generates paracrine signals, including adenosine-related signaling, that tell the afferent arterial to constrict. The clinical nuance is important. This mechanism is biologically plausible, but clinical acute kidney injury outcomes are not uniform across trials. The physiology gives us a reason to be cautious with large chloride loads, especially in susceptible patients. It does not prove that every saline exposure causes kidney injury. The next step is the hemodynamic consequence. Once the paracrine signal is generated, the afferent arterial constricts. That lowers glomerular capillary pressure and can reduce glomerular filtration rate. In a healthy volunteer, this may be transient. In a septic patient, a patient with chronic kidney disease, or a patient with low effective arterial blood volume, the same signal may be less well tolerated. So the bottom line is balanced. Large volume saline can cause hyperchloremia and non-anion gap metabolic acidosis, and it may contribute to kidney stress in susceptible patients. But outcome trials are mixed. The strongest practical conclusion is not never saline. It is use chloride-rich fluid deliberately. The human physiology studies help frame this. Human volunteer data give us a physiology signal. In a small crossover study, healthy volunteers receiving 2 liters of saline had lower renal artery flow velocity and lower cortical perfusion compared with plasma light. That finding is interesting, but it is not the same as proving clinical acute kidney injury causation. Healthy volunteers are not patients with septic shock, cirrhosis, heart failure, bleeding, or chronic kidney disease. Clinical outcomes depend on patient factors, illness severity, baseline kidney reserve, and the total fluid strategy. So we should use this type of study as mechanistic support, not as standalone proof. The next question is how clinical trials measure fluid-related kidney outcomes. Many fluid trials use a composite outcome called major adverse kidney events within 30 days, often called MAKE 30. It usually includes death, new kidney replacement therapy, or persistent kidney dysfunction, such as a creatinine at least 200% of baseline. Composite endpoints are useful because death alone is hard to shift with a single intervention like fluid choice. They increase statistical power, but they also combine outcomes with different clinical meaning. Death, dialysis, and persistent creatinine elevation are not interchangeable events. So when a trial shows a difference in MAKE 30, ask which components drove the signal, whether mortality changed, and how large the absolute difference was. That prepares us to interpret the SMART trial. SMART enrolled critically ill adults and compared balanced crystalloids with saline in the intensive care unit. The primary outcome was MAKE 30. The trial found a small but statistically significant lower rate of major adverse kidney events with balanced crystalloids. The absolute difference was modest but clinically relevant at scale, because fluids are so common. The sepsis subgroup suggested a possible larger benefit, including lower 30-day mortality, but that was a secondary analysis. It should support the hypothesis, not be treated as definitive proof of mortality reduction. The teaching point is that SMART moved balanced crystalloids from a physiologic preference to an evidence-supported default in many intensive care unit patients. But the next trial asks whether that pattern extends to ward patients. SALT-ED studied non-critically ill hospitalized adults who received crystalloids in the emergency department and were then admitted outside the intensive care unit. The primary outcome was hospital-free days through day 28, and that outcome was neutral. Patients did not leave the hospital meaningfully sooner because of fluid choice, but the secondary kidney composite, MAKE-30, was lower with balanced crystalloids. This is a common evidence nuance. A neutral primary outcome limits how strongly we can claim benefit, but a kidney signal in a large pragmatic trial still supports balanced crystalloids as a reasonable default for many hospitalized adults, especially when there is no specific reason to use saline. The larger blinded trials then complicate the story. PLUS and BASICS were larger blinded intensive care unit trials comparing plasma light type balanced solutions with saline. Both focused on 90-day all-cause mortality, which is a harder and more patient-centered endpoint than a kidney composite. The results were neutral for mortality and did not show clear secondary kidney outcome differences. That does not erase SMART or SALT-ED. It tells us the effect, if present, is not uniformly large across all intensive care unit populations. Why the discrepancy? Potential reasons include population differences, lower illness severity, pre-enrollment fluids, crossover patterns, blinding, and subgroup dilution. The practical conclusion is measured. Balanced crystalloids are reasonable defaults in many patients, especially sepsis, but they are not uniformly kidney-saving or life-saving. When we synthesize the evidence, the signal is not binary. SMART overall favors balanced crystalloids slightly. The SMART sepsis subgroup favors balanced crystalloids more strongly, but as a subgroup signal. SALT-ED shows a secondary kidney outcome benefit. PLUS and BASICS are largely neutral for primary mortality outcomes. Guidelines reflect that nuance. The Surviving Sepsis campaign supports crystalloids as first-line fluid for sepsis and suggests balanced crystalloids over saline during initial resuscitation, with saline favored in sepsis with traumatic brain injury. KDIGO's acute kidney injury guidance supports isotonic crystalloids over colloids for initial intravascular expansion, but it does not specifically endorse balanced crystalloids over saline. The bedside conclusion is stewardship, not ideology. Choose balanced fluids often. Choose saline when the indication fits. A useful way to avoid fluid harm is to stop thinking only about boluses and start thinking in phases. The life cycle moves from resuscitation to optimization to stabilization to evacuation. In resuscitation, the question is whether tissue perfusion is immediately threatened. In optimization, the question becomes whether more fluid will still improve cardiac output without causing harm. In stabilization, the goal is to prevent fluid creep. In evacuation, we actively remove excess fluid when congestion is now the dominant problem. The key point is that the correct fluid strategy changes over time. A liter that is appropriate in the first hour may be harmful on day 3. That brings us to the rescue phase. In the rescue phase, minutes matter. The goal is rapid restoration of effective arterial blood volume in life-threatening shock. A reasonable approach is focused boluses, often 500 to 1,000 milliliters, followed by immediate reassessment. The Clovers trial is useful here because it compared a restrictive fluid strategy with earlier vasopressors against a more liberal fluid strategy in sepsis-induced hypotension. It did not show lower 90-day mortality with the restrictive strategy, but it supports the idea that after initial crystalloid, persistent vasoplegia should not be treated with unlimited fluid. A practical question. If a patient remains hypotensive after the first couple liters and appears vasodilated, should we reflexively give liter 3? Often the better answer is reassess fluid responsiveness and consider norepinephrine. Rescue is not a license for unbounded accumulation. Optimization is where fluid management becomes more disciplined. The patient may still need circulatory support, but the question has changed. We are no longer asking, can fluid raise the blood pressure? We are asking, will additional fluid meaningfully increase stroke volume or cardiac output? And can the patient tolerate it? This is where static assumptions should end. A central venous pressure, a heart rate, or a dry appearing mouth should not automatically trigger more fluid. Instead, use a reversible preload challenge, point-of-care ultrasound, passive leg raise, or carefully titrated small fluid challenge, often around 250 milliliters. In this phase, every bolus is an active threat to lungs and kidneys, unless it has a clear physiologic purpose. In stabilization, the goal is zero or slightly negative fluid balance while maintaining hemodynamic stability. This is where unnecessary maintenance fluid often persists, because no one cancels it. The daily reassessment should be explicit. Can the patient drink? Can enteral hydration be used? Are there ongoing losses? How much carrier volume is coming from antibiotics, vasopressors, sedatives, nutrition, flushes, and electrolyte replacement? Is the patient still nil per OS, and is that plan still necessary? The teaching point is that maintenance fluid is not benign. If the gut works, use the gut. Intravenous maintenance should continue only when it adds value. Once congestion is limiting recovery, the next phase is evacuation. Evacuation, or deresuscitation, is active removal of accumulated fluid. The goal is to relieve pathologic congestion while preserving perfusion and kidney recovery potential. Fluid overload is not cosmetic. Myocardial stretch can impair diastolic function and reduce forward flow. Elevated intra-abdominal pressure and renal venous congestion can worsen acute kidney injury. Tissue edema can impair oxygen diffusion, lymphatic drainage, and wound healing. The tools are loop diuretics, combination diuretic strategies in selected patients, and ultrafiltration or kidney replacement therapy when diuretics are ineffective or unsafe. The endpoint is not a guess dry weight during acute illness. The endpoint is less congestion with preserved perfusion. To do that well, we need better measures than static numbers. The myth is that static measures alone tell us whether to give fluid. Central venous pressure, mean arterial pressure, tachycardia, and physical appearance can be useful context, but they are poor standalone tests of fluid responsiveness. Central venous pressure reflects right atrial pressure. It is influenced by venous return, right ventricular compliance, intrathoracic pressure, positive end expiratory pressure, venous tone, and volume status. A high value may signal venous congestion rather than useful preload. The reality is dynamic assessment. We ask whether the cardiovascular system is operating on the steep portion of the Frank-Starling curve. If a reversible preload increase raises stroke volume, fluid may help. If not, more fluid mainly increases venous pressure and edema. That is where dynamic testing enters. A passive leg raise is a reversible autobolus. Moving from semi-recumbent to legs elevated transfers roughly 250 milliliters of venous blood toward the central circulation. The key is not the maneuver alone. The key is measuring real-time stroke volume, or cardiac output, during the maneuver. A common threshold is a stroke volume or cardiac output increase of more than 10%. Pulse pressure alone is less reliable as the primary readout. Pulse pressure variation is a separate dynamic index. It can be useful only under strict conditions. Passive controlled mechanical ventilation, regular sinus rhythm, adequate tidal volume, closed chest and abdomen, and a good arterial waveform. It becomes unreliable with spontaneous breathing, atrial fibrillation, low tidal volume ventilation, right ventricular failure, open abdomen, strong respiratory effort, or poor waveform quality. Dynamic tests are powerful only when their assumptions are respected. Inferior vena cava ultrasound is attractive because it is quick, but interpretation depends heavily on physiology. In a mechanically ventilated passive patient, positive pressure pushes blood out of the chest during inspiration, and the inferior vena cava may distend. High variability can suggest fluid responsiveness in selected conditions. In a spontaneously breathing patient, negative pressure pulls blood into the chest, and the inferior vena cava may collapse with inspiration. Extreme collapse can suggest low right-sided pressures, but it is heavily confounded by respiratory effort. So the safer interpretation is this. Inferior vena cava size and collapsibility often estimate right atrial pressure and venous congestion better than they predict fluid responsiveness. Integrate it with the ventilator, right ventricular function, pulmonary pressures, abdominal pressure, and the clinical story. VEXUS, or venous excess ultrasound, shifts the question from, can I give more fluid, to, is venous congestion already harming organs? It evaluates Doppler patterns in the hepatic vein, portal vein, and intrarenal veins. Severe hepatic venous congestion can show systolic flow reversal. Severe portal venous congestion can show high pulsatility. Severe intrarenal venous congestion can show discontinuous, often diastolic only, venous flow. The most important caution is that VEXUS is a congestion assessment tool, not a direct measure of total body volume, and not a fluid responsiveness test. It must be interpreted with the full clinical picture, including right ventricular function, pulmonary hypertension, ventilator pressures, and trends over time. Used well, it helps identify when the kidney problem is not lack of fluid, but venous pressure. Sodium management is really brain water management. The number matters because it reflects tonicity and brain cell volume. In chronic hyponatremia, brain cells adapt by losing osmolytes. If serum sodium rises too quickly after that adaptation, water shifts out of brain cells and osmotic demyelination can occur, classically involving the pons but not limited to it. Risk is higher with very low sodium hypokalemia, malnutrition, alcohol use disorder, and advanced liver disease. Hypernatremia carries the opposite concern. Rapid lowering can move water into brain cells, risking cerebral edema, especially when hypernatremia is chronic or neurologic vulnerability is present. The clinical message is not paralysis. Treat dangerous symptoms, but control the correction rate and monitor closely. The next slide gives a proactive hyponatremia strategy. The AVP clamp is a monitored strategy for severe hyponatremia when unpredictable free water excretion could cause overcorrection. AVP is desmopressin, a vasopressin analog. Remember, vasopressin is also called ADH, or antidiuretic hormone. The threat is sudden echoresis. For example, after restoring volume in hypovolemic hyponatremia or stopping a thiazide, the kidney may abruptly excrete free water and sodium can rise too fast. The clamp uses desmopressin as the brake, often 1 to 2 micrograms intravenously every 6 to 8 hours in selected protocols, while hypertonic saline becomes the accelerator. Sodium is then raised deliberately toward a target. Monitoring is essential. Serum sodium every 2 to 4 hours initially, potassium, urine output, urine osmolality when available, volume status, and neurologic status. This is not locking the kidneys. It is controlling water excretion while correcting safely. Hypernatremia correction has less high-quality trial evidence than hyponatremia. Traditional practice estimates the free water deficit, accounts for ongoing losses, and gives electrolyte-free water by enteral route or as 5% dextrose in water. Sometimes 0.45% sodium chloride is used when some sodium replacement is also needed. The SALSA-2 approach is being studied to compare rapid intermittent electrolyte-free water, such as 5% dextrose in water boluses or enteral water, against slow continuous correction in severe hypernatremia. Until stronger outcome data are available, the principles remain practical. Treat shock or severe hypovolemia first with isotonic crystalloid. Then replace free water deficit and ongoing losses. Check sodium frequently. Individualize the rate based on acuity, symptoms, age, comorbidities, and neurologic risk. The final framework brings the whole lecture together. First, characterize the patient. What is the history, exam, baseline kidney function, medication profile, and time course? Second, identify and treat the cause. Infection, bleeding, obstruction, endocrine disease, drug effect, or ongoing losses. Third, select the intervention with precision. The right fluid, dose, rate, reassessment point, and stop point. Balanced crystalloids are reasonable defaults for many patients, but not universal. Saline still has important roles, such as selected hyperkalemia scenarios, chloride-responsive metabolic alkalosis, traumatic brain injury protocols, some large volume resuscitation settings, and severe symptomatic hyponatremia when using hypertonic saline. Finally, reassess and adapt. Monitor clinical response, electrolytes, creatinine, acid-base status, osmolality when indicated, and urine output. Stop or slow when the clinical goal is achieved or harm is increasing. As always, this discussion is educational and should not replace individualized clinical judgment or medical advice. Thanks for watching Nephrology Notebook. Subscribe for more nephrology and critical care teaching.